Do you really want to stick around for another 12 months feeling horrible, spending your day contemplating your next appointment? I don't think so. And you don't want to spend your life wringing your hands every morning, getting up saying, oh, I have prostate cancer. Whoa. No. We all have a terminal illness called life. I don't want you to die from prostate cancer. I do not want you to foreshorten your life with a heart attack. I don't want you to get a stroke. I don't want you to die from some other form of cancer. What I want is someday at a ripe old age, you just don't wake up, and that's it. Well, I've been telling you not to get a biopsy, not to do surgery, not to do radiation. But what if your prostate cancer goes to the bone? What if prostate cancer becomes metastatic? What should you do if your PSA level is rising, but you feel good? We're going to talk about how to manage that phase of your prostate cancer when things aren't going great. In the ideal outcome, the cancer is suppressed. It is contained within the capsule of the gland. Therefore, it never affects mortality. You live with it. We don't try to obliterate the cancer. We don't try to eliminate it. We keep it in its home, right there in the gland. But it can progress. Now, in conventional treatment, when the PSA starts to rise, the standard of care generally turns toward androgen deprivation therapy, a euphemism for castration. That's right. No testosterone. Why? It'll lower your PSA. All right, but does that matter? It's a surrogate marker. The PSA does correlate with the prostate cancer progression to a degree, but it doesn't predict an outcome. The PSA level can gradually rise over years while you feel great. Should you allow castration to occur because your doctor is nervous, making you nervous because your PSA just went from 5 to 25? Now, I'm not rooting for it to go up, and I'm not saying we should be passive. I do believe we should be actively engaged. I've shared with you elements of the protocol that I advocate for, but there is a place and a time to consider a form of androgen deprivation. And it's not early in the course, in my opinion. Now, there was a recent meta-analysis. That's when docs look at an array of studies, 26 different studies. And the question yet to be answered: if we're going to castrate a man to prevent death from prostate cancer or symptomatic progression, when should it be done? So there are some studies supporting the concept that if you do it aggressively and early, the potential outcome, that is length of life, maybe can be extended. Maybe. We're talking months, people, not years in most cases, right? At what price? When you get castrated, you will lose a vast reserve of your masculinity. Now, I'm not just talking about erection, sex drive. That's important for many men, but it's not the only element that is lost. Brain gets weak. Cognition diminishes. Dementia goes up. The risk of falling goes up. Bone fractures, gynecomastia, man boobs. Not many people are advocating for that. The risk of heart disease goes up. It is a toxic, harmful, and dangerous treatment to undergo. Now, despite its toxicity, despite its risk, there's a time and a place that I believe it has merit. I'm going to share that with you. And the time and the place is not because your PSA is rising. So I had a gentleman in my practice, his history of prostate cancer, being supportively cared for over 30 years, staying in the box. Then it started to go up. PSA starts to go up. Went up from 30 to 70, 70 to 90. And his other doctors were having kittens. Gotta castrate this guy. He went 3 years like that, feeling great, going to work every day. When do we consider it? So in my approach, what I'm advocating for is let symptoms drive the train, not your PSA. If your PSA goes up and you feel great, you're not having any symptoms of metastatic spread of prostate cancer, you can safely defer therapy. Now, why would you do that? Why not get started early? Can't I prevent bad outcomes? The evidence about its value when started early is not strong. It is ambiguous. It is unclear. When there's uncertain benefit, but guaranteed harm, you pause. That's my recommendation. You pause because you're going to hurt yourself. Why? When there's no proof of benefit at the back end. The time to do this, if you're going to do it, is when symptoms are present. What kind of symptoms? Prostate cancer, when it moves outside of the gland, most likely goes to the bone, and that will often herald itself with bone pain. So if there's bone pain, turns out to be prostate cancer, now's the time. Another consideration, local progression where you can no longer pee because the prostate is now so enlarged with tumor that it's obstructing urine flow. There's another symptomatic endpoint. On occasion, the prostate cancer can metastasize to other organs, liver, perhaps even brain. If it goes to other organs, now's the time. You see what happens, men, when you go on androgen deprivation therapy, guaranteed it will end up failing at some point. The prostate cancer, not maybe, not sometimes, all the time, progresses through androgen deprivation therapy. The term for that is called castration-resistant cancer. At that point, there ain't nothing left to treat you with that's reliably effective. Now we're really groping at what to do next. Castration-resistant prostate cancer is a prelude to death from prostate cancer. Therefore, we avoid castration resistance. So the analogy is like this. You're a Civil War soldier. You're standing behind a stone wall. You can see the enemy a mile away. Your musket only shoots for 200 yards. You got so much ammunition, but you're nervous. The enemy is coming closer. PSA rising. Stick with me on the analogy here. PSA is rising. Enemy's coming closer. You start shooting. Bang, 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 bang. It feels good. The enemy hears the gunshot and pauses. But they're not hurt. They still come forward. By the time they're at the stone wall, you're out of ammo. That's a bad place to be because androgen deprivation therapy always evolves into castration resistance. My approach is to delay. Then you can get years of good living, years of preserving the merit, if you will, of androgen deprivation therapy. Now, when it's administered, this is another area of uncertainty. In most cases, it is continually administered to lower the PSA, to lower the testosterone. That's considered success. Changing a number is not a goal worthy of sacrificing vitality for. Therefore, the success I look for, reversal of symptom. I had bone pain, it's gone. I couldn't pee, I'm peeing. My liver functions were off the wall, they're back to normal. That is a tangible effect. When that occurs, the standard of care in most cases is to continue androgen deprivation therapy in an uninterrupted manner until the PSA starts to rise and then declare it resistant. Many conventional doctors, and this is something I advocate, are now doing it intermittently. So you do androgen deprivation. There are a host of drugs. We'll get into those in future podcasts. There are different generations of them. You want the one that is most gentle, and yes, they're out there. Anyhow, you do the androgen deprivation therapy until you're feeling better, symptoms are under control. The PSA, yes, we track it. Yes, it should go down. Testosterone level goes down. But then you stop. You stop androgen deprivation. Why? Because the theory, the hypothesis, is by doing it intermittently, we can utilize it for a longer period of time, preventing resistance, and allowing revitalization so that you get a restoration of your vitality, a restoration of your health. A gentleman I'm working with went to a conventional doc at one point, prostate cancer metastatic. They put him on aggressive, oftentimes the conventional doctors do this, they'll put them on triple therapy, multiple androgen deprivation blocking drugs, sometimes even combining it with radiation or chemo, awful side effects. He could not work. If he doesn't work, he doesn't pay for his food and shelter. Now we're talking real life consequence. So he stops all of that and goes back to work, gets his energy back, feeling good, feeling good. Sometime later, symptoms start to creep back up. Now you can cycle. Keep vitality, keep working, cycle the therapy. And here's the next leap. We're now looking into, by we I mean some researchers in the prostate cancer field. At Johns Hopkins, they have pioneered some research for castration-resistant cancer. They're now using testosterone therapy to try to treat castration-resistant cancer. Now that sounds weird, right? You've all been taught, or many of us and many of you believe, that giving testosterone to a man with prostate cancer is pouring gas on the fire. All right, that presumption is being challenged by newer clinical experience and research evidence. In the Hopkins studies, they looked at men who had castration, and then the PSA started to rise. So they put them on a high-dose testosterone, intermittently crashing the T level. So high-dose testosterone, wham, it goes down. It turns out prostate cancer cells don't like that. They end up having their DNA ruptured. It can potentially kill some of them. And in the Hopkins studies, they found many of the men in the study group had the PSA level go down and had the cancers once more become sensitive toward androgen deprivation therapy. Well, that's kind of cool. Now, take it a step further. That is in a research protocol. And here's a problem with research protocols. I like research. I read it all the time. I publish some papers myself. It's hard to do good research, but the research never gives us the information we really, really, really want to know. It gives us some data. And ultimately, gentlemen, it comes down to you, your doctor, your philosophy, to take that data and turn it into an action plan. I've read lots of studies. Here's something I have never seen in the conclusion of any study. This study wraps up all data there is to know about this particular topic. This study can be considered definitive to the point where no further study is needed, right? That'll never happen. The conclusions are always the same. Well, this information is compelling. We call for more studies. Of course you do. And that's not wrong. The point is that you can't lean on them when you have to make decisions today. We, us. So what do we do with this information? Castration is horrible. It weakens me. But I have metastatic disease. My PSA is rising. What am I going to do? I'm in the box. Applying the information at hand in a revolutionary way to look at altering outcomes. What I've done in that setting in some cases is preempt resistance with applying the bipolar principles to men prior to castration resistance. In other words, metastatic disease occurs, it's in the bone. Androgen deprivation therapy, gentlemen, is okay, in fact, important, in fact, helpful in that setting alone. In my opinion, you don't do it just because your PSA number changed. You wait, because the outcome studies validating or at least do not demonstrate a reduction in your risk of death if you start early with these treatments. That's unclear. So you wait. Then you start androgen deprivation, but you plan on doing it intermittently, right? If you're in the midst of a treatment right now with your oncologist or your urologist, ask them about taking a break. Hey, doc, what do you think about this concept of intermittent androgen deprivation? I want to avoid castration resistance. They may well be on board with that because it's in the literature. The next step, though, is how about if you're that man with bone metastatic disease? Step one, you must control the bone mets. You cannot do testosterone therapy with active bone metastatic disease. That's clear. So step one, control the disease, androgen deprivation. But how about now that it's under control? Could you add testosterone in the bipolar manner that they're doing for men with castration-resistant cancer? Would that potentially extend the duration of benefit, extend the effectiveness of the castration therapy, and at the same time mitigate the negative consequence by periodically restoring the testosterone, getting a burst of energy, a burst of muscle vitality. Could we achieve a better quality of life? At the same time, we're extending lifespan. That's kind of exciting to contemplate. And I think that there's enough data, enough evidence to consider this approach. But you've got to be eyes wide open, guys. This is a challenging arena. No matter what you do, death from prostate cancer may occur. Ultimately, you have to be comfortable with the path you're walking because nobody's got a guarantee. I never want to see people have a retrospective regret looking back, the consequences, I should have done X instead of Y. Don't do that to yourself. Look, if you had your prostate removed and you have metastatic disease, do not lament your decision. It was the best you could make at the time. If you choose to pursue the protocol I'm advocating and your disease progresses, you can't look back with regret. You have to look forward with optimism, living well, accepting decisions in the moment you have to make them, and then take your hand off the wheel. I've seen some men so overwhelmed by their diagnosis, its treatment, and the blizzard of information that's available, consume their days Google searching, consume their days worrying, getting a PSA every week, every month. Look, where's my PSA? Back off. Don't let the cancer win by sucking the vitality out of you. You have relationships. You have things you like to do. Stay connected. Work with a provider you have confidence in. If it's me, if you're in my protocol, good, I'm happy. If it's not, and there are lots of good docs out there, you got to make a choice about the path you're on. Make periodic reflective moments to study and contemplate what to do next, and then forget about it, right? Go out and live your life. Why? Because you're probably going to live a long time. And you don't want to spend your life wringing your hands every morning, getting up saying, oh, I have prostate cancer. Whoa. No. We all have a terminal illness called life. I don't want to be trite. You guys are different. You have cancer. I get it. But remember, you're more likely to die from other forms of cancer, heart disease, stroke, perhaps even pneumonia, more likely to die from those consequences than the prostate cancer itself. Now, we want it all. I want it all for you. I don't want you to die from prostate cancer. I do not want you to foreshorten your life with a heart attack. I don't want you to get a stroke. I don't want you to die from some other form of cancer. What I want is someday you just don't wake up. Someday you go to bed with a chest cold and that's it. At a ripe old age with prostate cancer buried in your gland while you lived vitally. That's the key. Another 12 months, another 14 months. On balance, I'd say I would take that, but it's never on balance. These treatments, they sometimes correlate with extending lifespan. You got to look beyond the headline and look at the quality. Do you really want to stick around for another 12 months feeling horrible, spending your day contemplating your next appointment? I don't think so. Well, maybe you do. That's your prerogative. Anyhow, castration therapy has a niche. I advocate for it only, in my view, in my approach, when the disease has extended and is causing symptoms in the bone, in the organs, or in the capacity for urine flow. Treating a number with a toxic therapy may well be more harm than benefit. Whenever there's a guaranteed harm and an ambiguous potential benefit, you avoid the harm. All right. Well, I hope this helps a little bit, guys. I know it's complicated. I know you're thinking about your prostate cancer and wondering what to do, what'll come next. I hope you take some reassurance with the knowledge that it is safe to wait for a metastatic moment to occur. With the advances in late-stage disease treatment, that may well be your best approach to enjoy life at the fullest and to make these treatments more effective when you need them. All right, until next time, guys, gals, everybody, thanks for spending time with me. Talk to you then.